Welcome back, coders, CDI specialists, and healthcare leaders. This is it, the grand finale of our 10-part respiratory coding masterclass. Over a past 9 sessions, we've systematically dismantled some of the absolute most complex guidelines in the ICD-10 manual. In this final explainer, we're going to audit-proof your vaping-related coding, untangle a really tricky clinical scenario, and synthesize our entire journey into a high-yield master checklist. Today, we're locking down vaping guidelines, looking at a secondhand exposure case, previewing ICD 2026 updates, synthesizing our core rules, and wrapping up with some essential respiratory health tips. Let's get right into it. First up, we're looking at vaping guidelines and the ever-important U0 7.0. When a patient comes in with a direct lung injury tied to vaping, the rule here is absolute. U0 7.0 is your principal diagnosis, no exceptions. You don't just relegate this to a secondary spot. If the admission is for that vaping-induced lung injury, U0 7.0 takes the lead on your claim every single time. Now, this is where you've got to pay close attention to the hierarchy. You absolutely must code secondary manifestations. We're talking acute respiratory failure, pneumonitis, or even GI issues like diarrhea and abdominal pain. But, and this is crucial, that definitive UO 7.0 code completely swallows general respiratory symptoms. So if your provider documents a cough or shortness of breath, skip it. Do not code those separately. The definitive vaping diagnosis already covers the whole shebang. And remember to cross-reference those category U07 emergency codes. U00.0 for vaping sits right next to U00.1 for COVID-19. These are highly scrutinized emergency use codes meant for tracking major public health issues. Because the spotlight is on them, your sequencing accuracy here is absolutely vital. All right, let's test this logic with a second-hand exposure case. Picture this scenario. We have a 7-year-old asthma patient admitted with acute hypoxic respiratory failure and moderate persistent status asthmaticus. The trigger? Secondhand vape smoke from an adult in the house. So how do we sequence this without triggering an audit? Take a second and ask yourself, does U0 7.0 belong anywhere near this chart? Here is the pathway. First, we need J96.01 for the acute respiratory failure with hypoxia. Next up is J45.41. That's your combination code for the moderate persistent asthma with acute exacerbation. And finally, step 3, you assign Z77.29 to capture the contact with and suspected exposure to hazardous substances. Now, here is the real kicker. You might be incredibly tempted to slap U0 7.0 on there because a vape is involved, but the AHA coding clinic explicitly forbids it for secondhand exposure cases. U0 7.0 is reserved exclusively for the person actively using the device and suffering that direct injury. For a bystander? Absolutely not. It is strictly incorrect. Moving right along, let's preview the upcoming ICD 2026 coding updates. Get ready for a pretty massive shift toward relying on your clinical judgment. You can expect to see those rigid excludes 1 notes heavily converted into flexible excludes 2 allowances. Historically, excludes 1 rigidly dictated that 2 conditions could literally never be coded together. But clinical reality is messy, right? This shift to excludes 2 recognizes that a patient can actually have both conditions independently, allowing you to finally capture their true comprehensive clinical picture. Okay, let's step back and synthesize the core rules from our entire series. Think back to part 1. We started with foundational anatomy, identifying the pleura, the trachea, the actual structures of the lung. Why? Because visualizing the biological system is the absolute bedrock of documentation integrity. You simply cannot code accurately what you cannot anatomically visualize. It's like trying to navigate without a map. So your foundational checklist essentially boils down to this. You've got to master those combination hierarchies. If the manual gives you a single combination code that identifies all elements, like COPD with an acute exacerbation, you never split that into multiple codes. And you absolutely must know how to navigate the complex diagnostic overlaps between COPD and asthma. Nailing that logic down will save you from endless denials. On the advanced sequencing front, always prioritize acute respiratory failure. If ARF is the chief reason for the encounter, that's your principal diagnosis, period. Also, make sure your providers are hitting those strict documentation criteria for ventilator-associated pneumonia. You can't just assume VAP. The provider has to explicitly state the causal relationship. And of course, keep those precise vaping rules we just covered top of mind. Finally, let's wrap up with some essential respiratory health tips. We've learned some truly amazing facts throughout this masterclass. I mean, our lungs are the only organs that can float on water. They pack over 300 million air sacs, and they can actively clean themselves. It's wild. You take roughly 22,000 breaths a day, so it's incredibly vital that we protect that system. To keep your own airways in peak condition, obviously avoid smoking and secondhand exposure entirely. Exercise regularly to build up that lung capacity, and maybe incorporate deep breathing or yoga to maintain tissue elasticity. If you're in a high pollution area, run an air purifier. And honestly, one of the easiest things you can do, just stay well hydrated to keep your airways moist and clear of mucus. Well, thank you so much for joining me on this incredible 10-part journey to absolute documentation integrity. I really hope this explainer series has equipped you with the clinical insight and the precision you need to tackle any respiratory chart that hits your desk. But as clinical realities and guidelines inevitably keep evolving, how will you adapt your strategies for the unknowns of tomorrow? Keep your coding audit-proof, stay curious, and as always, decode healthcare with Harshal.